So for starters, DIC is not an actual disease, but instead it's a sign of an underlying condition. So it might be triggered by things like sepsis, trauma, cancer, shock, your allergic reactions, or other conditions. But it's essentially a normal hemostatic mechanism that's altered, and it's a syndrome of activated coagulation that's characterized by bleeding or thrombosis, and it's essentially a complication in disease and conditions that would alter the clotting mechanism, and it can cause occlusion of small blood vessels or like organ necrosis or depletion of circulating factors and platelets and so forth. In regard to the manifestations of DIC, patients that have it might bleed from their mucous membranes or from the venipuncture sites or from the GI or the urinary tracts. And the bleeding might be able to range from, like minimal internal bleeding to a profuse hemorrhage that includes all of the orifices. But ultimately, whenever you're assessing a patient for DIC and you're looking for signs and symptoms of it, you want to consider the organs that are involved, because the organs that are involved determine what kinds of signs and symptoms that you would be looking for. So, for example, if skin is involved, then you might see some bleeding from like the gums, or the oozing from the wounds, or previous injection sites like around catheters, like IVs and stuff. But if it's like the circulatory system, then they might be experiencing tachycardia. Or if it's from like the respiratory system, then they might have like tachypnea, signs and symptoms of like acute respiratory distress syndrome, and so forth. So some risk factors for DIC are patients that are experiencing things like sepsis, trauma, cancer, shock, allergic reactions, or other conditions such as, like a cardiac arrest. So DIC is a dynamic condition, and the laboratory values that are measured will be changed over time. But some of the laboratory values that are commonly found in DIC are the platelet count that is decreased, the prothrombin time is increased, the partial APTT is normally increased as well. The thrombin time is increased. The fibrinogen is decreased. The D dimer is increased, and the FDPs are increased, and the clot lysis is normally less than an hour whenever the norm is greater than 2 hours. So, in regard to the nursing interventions and the management of DIC, one of the biggest things that is most important about all of this is that nurses need to be aware of which patients are at an increased risk for DIC, and they need to be thoroughly assessed and frequently assessed for signs and symptoms of bleeding, and monitoring for any progression of these signs. So, essentially, that you want to focus on the early recognition of signs and symptoms whenever the patient is experiencing abnormal bleeding, and you want to like treat the underlying condition of it to prevent further bleeding from occurring. And on top of that, you want to be able to provide them with emotional support and make sure that they are able to express and verbalize any concerns or fears that they have, and to ultimately be able to educate them moving forward. You want to be able to provide them with an adequate amount of rest periods whenever they are participating in activity, just because this energy might reduce like the overall oxygen that they have, and it might tire them down pretty quickly. You want to give them any pain medications that is necessary that they have prescribed. You also want to make sure that they have like compression stockings and stuff to be able to prevent VTE. And then on top of it, you also want to make sure that they have a pulse ox attached at any given point, or they get fairly frequent ABGs done to give them, the prescribed oxygen therapy that they might need, and ultimately evaluate their oxygen saturation levels. So DIC ultimately only develops in approximately 1% of all hospitalized patients, but those that have sepsis, it occurs in anywhere between 30 to 50% of cases of patients that are experiencing septic shock. So there's not really any particular predisposition that's been associated with this that would increase their risk for developing this in regard to their ethnicity, race, sex, anything of that nature. But it honestly depends on the underlying condition that led to DIC as to what their prognosis looks like. But then there are a lot of other factors that are also considered in that, which makes determining a specific figure with its morbidity and its mortality rate, very difficult. But you know, for example, in a patient that has major trauma, the presence of DIC essentially doubles the mortality rate. And then, you know, for a patient that is there for sepsis and they have C. diff and they are experiencing shock on top of it, then their mortality rate is up to 50%.